All right. Okay. Again, welcome everyone. For those who are new and who just joined the meeting, my name is Lakeisha. I am the support programs manager here at the Hydrocephalus Association. I am going to introduce our speaker and then I will turn it over to him. So Dr. Jeffery Schaffert is currently a clinical neuropsychologist who serves as an assistant professor of psychiatry at the University of Texas Southwestern Medical Center, where he also completed his doctoral and residency training. Clinically, he sees outpatients in the UT Southwestern Neuropsychology Clinic and inpatient at the University Hospital there in Texas. He has published several papers on the risk factors of Alzheimer's disease and related dementias, but his primary research interest continues to be the impact of head injury exposure and later in life cognitive decline. So we are so very happy that you were able to join us and share your knowledge and time with us, Dr. Schaffert. So I am going to turn it over to you so that you can start sharing your screen.
Awesome, thank you. Well, thank you for having me. Seems like a really great organization, and I'm really happy to present at it. I can't see. I'm trying to expand all of you to see on my screen and my other screen here, but I don't know if I can see all of you. But if you have questions, I am happy. I'm really flexible, so you can go ahead and interrupt me. That's fine with me. Um, and we'll have some questions at the end too, some time for some questions to answer in the end. But so I'm going to talk to you all about neurocognitive features of iNPH, or idiopathic normal pressure hydrocephalus. And so let me tell you a little bit about who I am and what I do. So as Lakeisha said, I'm a clinical neuropsychologist. And for those of you who may have not had exposure to a clinical neuropsychologist, many of you might have already, but I'm a psychologist. I'm a clinical psychologist by training. So I have a PhD in clinical psychology, but I also have specialized training in how the brain impacts behavior. So behavior being emotions, but also cognitive skills, memory, thinking skills, attention, language skills. And so we measure those things and we assess how someone's brain is functioning. I exclusively work with patients who either have neurological disorders or suspected neurological disorders, and I assess how their brain is functioning through specialized measures that we give, but also how we observe their behavior and taking a good history from you and your significant others and family members to try to get a sense of what changes have been going on. And I'm part of the NPH world. I was asked to join in through the inpatient assessments at the hospital. I was doing pre and post lumbar drains, and many of you may have had those done before. And so I was actually asked to help develop a clinic here at UT Southwestern, an outpatient clinic for patients who have suspected NPH. And so that's kind of how I've been involved. I've been doing that for about a year now. I've been doing the lumbar drains for a few years. Um, and my job on that team is to help the patients understand their diagnosis, the impact it may have on their functioning, but also assess for improvement with any diagnostic procedures we do, and then also help guide the neurosurgeon and the patient to help figure out what their potential response could be to getting a shunt. And so that's sort of my role in a nutshell with the NPH team here at UT Southwestern. So I'm going to take you through a little bit of an outline. We're going to do a brief history of NPH really quickly. We're going to define what NPH actually is and kind of review briefly the clinical features. How do we go about diagnosing NPH? It's a really tricky diagnosis to make. I tell my patients that all the time. Um, and what are the cognitive difficulties that are associated with NPH? And how do we distinguish those cognitive difficulties from NPH from other possible sources? Um, and then after somebody may get a shunt, what happens with their cognition after that? Is there any additional cognitive changes? And then we'll have some time at the end for question and answer. But again, please feel free to interrupt. I'll be happy to answer any questions as we go along. So, really quickly, a lot of people don't know, but NPH is pretty recent phenomenon. It was only really discovered, the first history of NPH that goes back was Professor Hakim out of Columbia, and the country Columbia, not the university. So he identified really several patients, and he threw together this case series of patients. And a fun fact about this, the initial case series he presented was actually in the New England Journal of Medicine, a very prestigious journal. But the author, the one of the authors on his paper, really scoffed at the idea that NPH could be a real thing, and that controversy still is somewhat prevalent today about NPH. But eventually, that author came around, and he actually was the lead author on that seminal paper that was published in 1965. And then, even then, one of there's a lot of people that didn't really necessarily believe in it, but one of the U.S. consulate employees in Colombia came to Dr. Heap after just a few months after he published that paper, and Dr. Heap, they couldn't do the procedure in Colombia, or the patient wouldn't want to do it there, so he flew all the way to the US and at Mass General and did the procedure himself. And I don't think that would fly, so to speak, today. I don't think you could go ahead and just fly a patient out of the country and perform a procedure. I don't know how that happened, but interesting, really fascinating story with the discovery of NPH and what it means. So, what it really means, it's a form of hydrocephalus or extra fluid on the brain, right? And it leads to enlarged ventricles or ventriculomegaly. We'll just call it enlarged ventricles. And the normal, so people always ask, well, what does the normal mean in the normal pressure hydrocephalus? It means that the pressure inside of the system is normal if you measure it when you take out spinal fluid at your spine. That's what the normal refers to. It doesn't mean that the amount of fluid is normal. It just means that the pressure has regulated itself and it's normal again. So this can be explained really by thinking about it this way. If you blew up a balloon and pretend your balloon are ventricles, eventually that pressure is initially high to blow up the balloon, right? That would be like extra fluid coming in. But as the fluid increases, the amount of pressure per surface area, because the balloon is increasing or the ventricles are increasing, it regulates and it becomes normal again. So that's how this can happen and be explained. And so you can think about it like blowing up a balloon. The pressure initially is there to increase the amount of fluid or increase the air, and then eventually it normalizes. And that's where the normal pressure hydrocephalus comes from. Okay. So when we talk about NPH, there's two types of NPH. There's idiopathic normal pressure hydrocephalus, which is what most of the patients come and see us for in our clinic, when meaning there's no identifiable cause, and it almost exclusively happens in the elderly, so patients who are like 55 to 60, 65 and up. There's also something called secondary normal pressure hydrocephalus, where the cases with the risk factors are when we have earlier brain infection, they might have had an injury and hemorrhage that prevents the flow. They may have had traumatic brain injury or some sort of radiation from tumors, something along those lines. And the treatment for that is still the same. But either than that, these conditions can cause some sort of inflammation and then prevent the uptake of your cerebral spinal fluid. Okay, so I'm not going to spend a lot of time on this, but we don't know what the cause of is. These are all the possible causes. We're still working as researchers to figure this out. It could be that people have just congenital hydrocephalus that eventually becomes symptomatic. They've had it their whole life, and now they're just noticing symptoms. It becomes a problem. Could be cerebrovascular disease. It could be the different other problems that's causing the reabsorption of the cerebral spinal fluid to get out of the brain. It could be the venous system is malfunctioning, or it could be a type of presentation that's associated with something else, like Alzheimer's disease or a different neurodegenerative disease. And so it's really, we don't know exactly what causes it, but these are the leading theories right now. It's very rare in comparison to other types of dementia and other types of cognitive problems in older adults. We don't exactly know what the incidence or the prevalence is. It ranges a lot depending on the sample you're looking at. It's about affects both men and women equally, we think. And usually most of the latest research is coming out of Sweden and their population base. They have a large NPH registry there, is that it is the ventricular enlargement is seen in about 0.2% of people 70 to 80 years old, and then about 6% or more for those who are over 80. And again, we don't exactly know like how many people are getting NPH every year. It goes undiagnosed, and it's very tricky to diagnose. And so it becomes more of a problem. And all of you know what the three features are of NPH, the three W's. This is what I learned as I was going through neuropsychology training, of the three W's of feeling wacky, which is the cognitive issues, feeling wobbly on your feet, and wet, having the urinary incontinence, urinary dysfunction, right? However, a gait dysfunction or the problems in walking is a really cardinal feature, and I think it should be present really for the clinical diagnosis of NPH. Uh, it's hard to diagnose NPH without some sort of gait dysfunction, because those are the individuals that tend to have the best response to the procedure or the shunting. Okay. So a few other things that happens, with the gait problems, it's usually insidious, meaning usually there's not a clear cause that seems to come out of the blue, and it usually gets worse over time. And the gait is typically very wide based, so your feet are wide apart, you feel stuck to the floor, you have magnetic gait, they're typically slow. Sometimes it can be shuffled, where you can't get your feet off the ground very, very far. And then what's called en bloc turning, which is a feature where you get to a point and then you start to turn, and the person with NPH has to take these kind of shuffling steps, and they can't quite turn very easily, and they have to take a lot more steps to turn. It's hard to distinguish between this and other disorders, but generally people that have Parkinson's disease or some other type of Parkinsonism, typically it's a little bit more narrow, and usually they can get better or they can improve their gait if you're giving them some sort of cadence or some sort of music to go to it, some sort of rhythmic cue. They can tend to get better. Patients with NPH have a more difficult time doing that. But for the urinary symptoms, it usually starts with urgency and then it gets worse over time. This is a really non-specific finding, and it can be caused by recurrent UTIs. It can cause from neurogenic bladder. It can be some sort of prostate issue for males. It can be all sorts of things that cause urinary incontinence. So it's a hard thing to say that somebody has urinary incontinence, therefore they have NPH. It doesn't really work that way. Clinically, though, if somebody has chronic incontinence, it can lead to UTIs. And the UTIs and somebody who has some NPH going on can cause some more problems with their thinking and memory because if they get delirious. And so that can be a nasty cycle too that we sometimes have to deal with in the hospital setting. All right, so let's talk about what are the typical cognitive symptoms of NPH. So early on, what the symptoms look like are really three different things. So what patients tend to notice and what the research suggests is that patients typically have some problems in attention, where they have a hard time concentrating or staying focused. They have processing speed issues where their responses to questions are slowed. Their processing of information coming in is slow. Their speech may be slowed as they're getting it out. And they also have executive functioning problems, which is a really big fancy term, but essentially what it means is problem solving or multitasking. I mean, there's a lot of different elements of executive functioning, but these are the typical things that you see early on in those who have NPH. And then a lot of questions are, what about memory? Patients complain a lot about memory. Well, sometimes memory is not what patients think that it is. So attention, for example, can look like a memory problem. Okay? In NPH, usually it is not specifically memory that's the first cognitive symptom. It can be, but it often is not. So Memory, in general, is referring to the ability for somebody to learn information and retain information after time has gone by. So sometimes what happens is a patient has so slow processing speed and so slow bad attention, what happens is they can't attend to the information coming in and they can't process the information coming in. So it becomes more of an issue with those things being significant and looking like a memory problem than actually a true memory problem. Though the longer then the symptoms go on, the more and more likely memory is eventually going to become affected. Okay, so but usually it's not the first symptom, right? All right. So this is how we go about diagnosing NPH. It's a very tricky thing to diagnose. So the first thing is you have to have these clinical features, and I would argue, and there is no gold standard diagnosis, meaning that it's not like if somebody has gait impairment this long and cognitive impairment this long and enlarged ventricles, this is the known to be the best diagnosis we have for NPH to really predict their response to treatment. Uh, that hasn't been validated yet, and it's really tricky to validate for a couple reasons. But uh, the best practices that we have available now are that gait issues should be a primary feature, and that you have to have at least cognitive dysfunction or urinary incontinence as well. But gait should be, you should have at least gait problems and hopefully one other symptom for us to really be more confident in it. And then the other thing is the MRI is key. So having a good high quality MRI or magnetic resonance imaging to really look at the ventricles and look at the brain and look at these features that we're looking for NPH. So these are all the different features. I'm not going to go over these in detail, but typically, hope you guys can see my cursor here, but typically what we're looking for is these are your ventricles, this black spot here, right? And some of you may have seen this before and others may haven't before, but these should be, this is a patient with NPH, and this should be a lot smaller than this. These should be more rounded. They should be closer to like where my, and finishing kind of where my, but they look like Mickey Mouse ears, and they shouldn't look like that. They should be a lot more curved, and they should look more, a little bit more like wings rather than big ears like this. Okay. So what happens is that it kind of pushes the brain up toward the skull. That's where this is being circled here. So we're looking at this brain here head on from the front. And then you'll also see these this extra fluid that's getting trapped inside the different areas of the brain there where it shouldn't be. Okay, so that's typically the features that we're looking for when we're looking at MRI scans. So if you have these features plus the clinical features that we're talking about, that's typically a good diagnostic sign for us that you probably have NPH. That being said, you can also have a brain that looks like this and not have any clinical features of NPH. You don't have any gait problems, you don't have any cognitive problems, you don't have any urinary problems. So that's what makes it really tricky. And sometimes you have patients that have very mild forms of this, but have significant clinical symptoms. So it doesn't always match up. And that's where the diagnosis being difficult to make really comes in. Okay. So I don't know how many of you have gone through NPH or have, had a shunt, but typically there's, we come to somebody like me and Dr. Sullivan and Dr. White over at UT Southwestern, and we all evaluate you and we say, all right, well, this is the next step of treatment or the next confirmation test that we'd like to give. Okay. So if you do it, you would do either a lumbar drain where they stick a needle in your back over and you go to the hospital and they pull out a bunch of fluid and then we test you to see if your symptoms improve, or we do it just one time. The problem is that if you do improve on those tests, they have really good positive predictive value, meaning that we have a good idea that you would improve with a shunt, right? But not necessarily if it's negative. If it's negative, still about half to 2/3 of people that still have a negative trial or a negative response to that trial still could improve with a shunt. So it has really bad negative predictive value. And so again, a lot of times the reason that people will go with the diagnosis of NPH is they say, well, you improved with it, so it confirmed our diagnosis. But the actuality is that sometimes people still have it, and this doesn't confirm the diagnosis at all. So it's a very tricky thing to do and a tricky area to be. Um, but I want to spend the rest of the time talking about how do we separate NPH from other disorders. So specifically, how do we separate the cognitive features from other possible sources? Well, a neuropsych or neuropsychological evaluation is a way to do that. And it's not sufficient enough just to go to your doctor and say, and have them do a 10-minute screening with you. Because unfortunately, the brain is very complex and we can't just assess it in 10 minutes. Okay. We have a lot of function that goes on with the brain, and we really need to do a more comprehensive evaluation to do that. So, for example, if you came to me in the clinic, I would do about 45 minutes of testing with you. And if you came to me where I'm sitting now in the outpatient clinic, I would do about 3.5 hours of testing to really get a good sense of how somebody's doing. So the way that we do it in clinic is I sample a lot of things. It's more than a screening, but it's not enough. It's not going to take 3.5 hours to do because we're seeing the demand is too high. We're seeing 5 patients in an afternoon. So it's just not feasible to do that. So, but a neuropsych evaluation is really one way for us to do that. And so what we do is we take these scores, we take these performances that people have in memory and attention and problem solving, and we compare it to other people their age. So that way we take age out of the equation and we are asking the question, do we assess for how the brain is functioning that is worse or better than expected for somebody's age? Okay, so that is essentially what we're doing. We're trying to answer, three real key questions for all the patients that we see. We want to know, how is their brain functioning? So an MRI takes you a picture of the brain. You can tell us about how you think you're doing. A person's spouse can tell us, which is really important because we have to marry all this up together. But the neuropsych eval tells us how is someone's brain functioning, what are the strong, weak performances, what are the consistent areas of impairment or problems that we see in the different areas. And then it helps us figure out, based on that pattern, why it may be happening. Is it consistent with what we know with NPH, or is it more consistent with something else? And then the last question is, what can be done about it? How can we help you function from a cognitive compensatory? Can you use any strategies to help your memory? Can we use any strategies to help your attention? Can we give your loved one some strategy to help communicate with you better? And then, we can help try to figure out what the treatment options are and how do we mitigate any cognitive risk, moving forward? How do we mitigate any cognitive decline that may be in the future? So here is just an illustration of how complicated this can be when you're looking at a patient. These patients all may come in with a quote unquote memory problem, right? But this is all the different types of things that we may measure up at the top. And these are all the scores they may get. And it just varies a lot by the typical clinical syndrome that we're seeing, whether it be Parkinson's, NPH, Alzheimer's disease. So it all can tell us different things, right? So this is kind of how we kind of look at these patterns of functioning and say, well, that fits more with this disorder versus this disorder. So one possible source of cognitive decline that people may have when they come in is just simply age. So I'm 35 years old and I'm starting to get past my prime. So unfortunately, our memory all gets a little worse as we get older, and that's normal. The question is, how much loss is normal, right? So here's a good example. This is somebody's memory, and they look at all these patients, and their memory with age, after about age 35 or so, starts to get worse. Same thing with somebody's ability to reason with information and problem solve, their visuospatial skills, and their speed. Look how much their speed declines as they get older. So the question becomes, how much is too much and how much? And so that we do that by these tests that we give are given to thousands of people. And that way we can gauge with a really educated statistical guess where somebody should be, right? this isn't all doom and gloom. Other things get better as you get older, like your vocabulary, your ability to get facts in, you learn new things. I don't think it's all that bad. But age is one of those things that we really have to account for, because same performance in somebody who's in their 50s is not the same as somebody who's in their 80s. It means two different things. All right, so other possible reasons that people may have cognitive decline besides NPH that may come in for a differential or trying to figure out a diagnosis is Alzheimer's disease. Okay, so the difference between Alzheimer's disease and dementia is that dementia is an umbrella term that means it's a symptom, right? It means that somebody has enough cognitive problems where they have problems living alone, they can't function on their own. They may have trouble remembering to take their medications, drive, get their way around, figure out what clothes to wear. Those are symptoms of dementia. Now, dementia can be from Alzheimer's, NPH, Parkinson's disease, strokes, lots of things. So dementia can be is a symptom. The most common cause of dementia is Alzheimer's disease, which is a very more specific disease, and the it's a high prevalence. Unfortunately, uh, most patients past or a lot of patients past the age of 80, about a third of them in the United States have Alzheimer's disease. And so it's a very tricky thing to make. And there's different severities. Many of them have mild stages of it, but it's a high prevalence. And so whenever somebody comes in with NPH, because NPH is also, idiopathic NPH is also a disease that a lot of people have when they're past the age of 80, we really have to think, do they have Alzheimer's disease as well or instead? So that's a really tricky question to come up with. But typically what we're looking for is that they don't typically usually have gait problems. They don't typically have urinary problems. Typically they have very early on, they have very focal problems with short-term memory loss and rapid forgetting, meaning they're not forgetting information that happened in their, 50 years ago. They're forgetting information that was just spoken to them 2 minutes, 3 minutes, 10 minutes ago. They can't remember that information, and they may repeat themselves over and over and over again. Patients with NPH may have sometimes that happen, but they usually get better when somebody says, "Hey, Gary, you remember we talked about that?" And they're going to say, "Oh yeah, I remember now." Yeah, so it may be that you have a memory lapse, but you didn't forget it completely. And so that's where the difference usually comes in. And so on testing, that's what it looks like to us when we look at the test results. Okay. All right, a couple other diseases that I'm going to go through pretty quickly here. There's another disease called dementia with Lewy bodies, and Robin Williams had this disease. Okay, so this is a disease where you have progressive cognitive change leading to a dementia, but you also have problems with acting out your dreams. So you may move around a lot in your sleep, reach for things, kick for things. They may have a lot of problems with their attention. They may fluctuate day to day. Some days are really sharp and other days are really, really confused. So it's a very pronounced change. They also have visual hallucinations. They see things that aren't there. They see people that aren't there. They may see little animals. That is not typically a feature of NPH. And they also have Parkinsonism, which can look a lot like NPH. They have tremor, they may have shuffled gait, they may have muscle stiffness, they may slow their movements down. So you can see if somebody has cognitive issues and Parkinsonism, they may come to our clinic thinking they may have NPH, and we have to help try to tease that apart. And on testing, it looks a little different. Typically, patients, they have a lot of problems with visuospatial skills, and they also can have memory problems too, because about 40% of the time they also have Alzheimer's disease. They typically share those two disorders together about 40% of the time. So you can have two things. Another one is Parkinson's disease. Okay, this is another one that many people with NPH are diagnosed with first. They're diagnosed with Parkinson's disease first, and some of you may have had that experience because the first symptom is usually a progressive one-sided tremor they usually have. They also have slowed movements, shuffled gait, and muscle rigidity. So the gait symptoms can look a lot like NPH. But, however, in people with Parkinson's disease, typically the cognitive issues are really very mild at the beginning. They may not be there for at least several years until after movement starts, problems start. And on testing, they typically have very slow processing speed, poor attention, and executive functioning problems, which is the same kind of symptoms of NPH. So this is a really tricky one to disentangle. Uh, However, I think the biggest thing is that typically they respond to treatment. So if you give somebody a Parkinson's med, they're very effective at reducing those symptoms. And if you give that same med to someone with NPH, they may not respond to that, and they may have more cognitive problems. So that's why when we do testing, we really need to help figure out, is this somebody that has, significant cognitive issues, or is this someone that has very mild and subtle issues, and maybe fits more with Parkinson's disease? So that can be really tricky. There's also some other atypical, what we call Parkinsonisms, that look like Parkinson's disease, but they have different names for them. I'm not going to go over them in detail, but here are some of the features that happen. And one of the main ones are that they have eye movement abnormalities. So they can't look left or right or up or down. That's typically a good feature. They also may have falling blood pressure if they get out of the chair too quickly. And they may have a lot more falls. But these are rare disorders that happen, but they are important rule outs for us. And that's why we have a movement disorders neurologist in our clinic. So they can assess their eye movement and do a full neurological exam to really assess for these types of features. Okay. But cognitively, they can also look very similar. And so again, you have to tease these apart because we certainly don't want to put a shunt in somebody who doesn't have NPH. That would just increase unnecessary risk for people. You also can have cerebrovascular disease. So these are diseases that, it's an umbrella term, but it basically means if you have anoxia to your brain, either through strokes or you have uncontrolled risk factors like diabetes, hypertension, other heart conditions that are really impacting how the brain is functioning. And you can look and see those on MRI scans as well. Okay. All right. I'm not going to go over a ton of the treatment, but the only treatment we have is a shunt. Okay. And so the question becomes, is it a good time to shunt a patient? Can we predict their improvement? And that's tricky. There are some complications with it. There really is only one currently going on. A lot of the criticism is that there isn't enough information to show how effective a shunt is. I know a lot of you in this room, in this chat, would disagree with that because you've had good success and good response with a shunt. However, there's not a lot of good data. And the reason there's not a lot of good data is that it's hard to say, hey, guess what? You are not going to get a shunt because you're part of this research study, even though we think it could benefit your symptoms. But we gotta withhold that for you because we need to do a study on it. Well, we can get around that. And there's one trial going on called the PENS trial. And UT Southwestern is a site. And it's really ingenious. The design of it is really sharp because everybody gets a shunt. So if you sign up for the study, you're going to get a shunt either way. But now you can turn the shunts on or off. So all that happens for patients that don't get they're in the negative group, their shunt is simply not turned on. So we basically give everyone a surgery, give everyone a shunt that we think has NPH, and then we say, all right, well, these patients we didn't turn on and these patients we did, and we're going to see how their symptoms respond. And then after 3 months, we turn everybody's shunt on. So really everyone gets the treatment. It's just a matter of, do you get it now or do you get it 12 weeks from now? So that's really kind of going to help us kind of really show the effectiveness of a shunt. And we're testing really what the cognitive scores have been. We only have 18 people so far. So we don't have a lot of data. This was just published in 2023. And so far, we're finding that people are getting better in their gait. It looks like they're faster, and their bladder symptoms or incontinence scores are also improving if they get a shunt and it's turned on. But so far, we don't have a lot of cognitive data. And so far, we're not seeing the cognitive scores have improved. So really what happens after a shunt, when we look at all the data, it's pretty mixed on whether people get better, like their memory or thinking skills get better after a shunt, or they stay the same, or sometimes patients get worse. And it's really mixed. We don't know, we don't have a good way of predicting how a patient will do. If they do get better, if their cognition does get better, so if I test somebody and it gets better after they do a lumbar drain, The good news is that I feel a little bit more confident saying, you know what, if you get a shunt, I think your symptoms are going to improve from a cognitive standpoint. However, that's not, I can never promise anybody that, because sometimes what happens is even after you get shunting, your symptoms may improve for a while, and then after that, it can start to get worse again, right? And that could be after just a few months, or it could be years of improvement, and then it starts to get worse, right? So when to be concerned about that is if you see a drastic change in you or your loved one's ability to function the same way. They can't remember to take their medicines anymore. They're making mistakes at work if they're still working. They're getting lost, around. They're getting lost in familiar places. They're having accidents when they drive, and their gait is getting worse on top of that. That says, all right, well, maybe the shunt either isn't working anymore or the shunt is no longer going to be effective for this patient, right? And so sometimes, unfortunately, that happens. And you can ask your neurosurgical provider, your neurosurgery team, if you think that their adjustment is prudent. And we can be evaluated by a neuropsychologist to really see how much cognitive decline there's been, right? And so that can kind of help us guide the rest of the treatment. So I think that's a good and to try to help figure out how to best help this patient. So unfortunately, we don't have good data on how if cognitive improvements really are beneficial. But I can tell you anecdotally, we've seen a lot of patients improve pretty substantially. But we are currently trying to get more patients to come back after their shunting for a more comprehensive evaluation to see how much the shunt has helped them. So we can really study this a little bit more. So if any of you have gotten a shunt at UT Southwestern with Dr. White, uh, you can ask him to see, you can see, or Caitlin, his nurse practitioner, you can say, hey, I'd like to, participate in research, see if there's anything to do, and we'll kind of gather some interest and see if we can do some more long-term outcome studies. Okay. But right now, I'm going to stop there and I'm going to see if any of you guys have any questions as we go along. Maybe some have come up, but I'd be happy to explain things again or ask any other questions you may have if it's related to NPH or cognitive decline in general. So, but thank you. It looks like we got a couple of them. Go ahead, blurt them out.
Uh,
Uh,
I see Sarit's hand
yeah, I
first.
see Saria's hand. Let's do that one.
Yes, hi. I'm just so I will be honest that I feel as though I know all of this information. My father has now had his shunt replaced. This is the third time.
Okay.
He's had really, really good results. And then, but the communication with the medical professionals has been abysmal.
Oh, sorry.
It's hard to know where to go, who to talk to. And, when you say things like, oh, you should come in and get testing,
Mm,
it's not that simple.
mm,
It's like when you're dealing with insurance companies and you're dealing with having
yeah.
to make payments and, the person's feeling good some days and not good other days. And the surgeons are pretending it's not the shunt. um, some of them just don't want to deal. They want to put in the shunt and then that's it. They don't want any more interaction. And it's hard to know where to get assistance. And
Yeah.
honestly, the shunt was incredible. Like the difference
Yeah.
it made was incredible. And then it failed. And then he had it replaced. She didn't do a good job. He was kind of stuck in that for a couple of years. And then we found another surgeon after searching and searching and searching, and every surgeon refusing to operate on him because he was 90. We
Yeah.
finally found someone who did, and the improvement again was very good. But now we're sort of stuck in this limbo again because he has ups and downs, and it's a whole different thing. Now it's something with my mother and not knowing how to deal with her. She's kind of tired
Yeah.
of the ups and downs.
Yeah.
It's hard to know where to go for help,
Yeah, where do you go for help, right? If you're not going to get it from the neurosurgeon, and yeah, I could see that. I could totally see that, a neurosurgeon doesn't deal with that. Um, so do you have a good, do you have a good Alzheimer's association to kind of help with some of those cognitive features in your area? They can provide a lot of information. They can actually provide some caregiving resources too. And it may be it depends on what you need help with. I mean, if it's behavioral management or tips and cues that kind of help deal with a loved one that may be having some cognitive decline, unfortunately, I don't have good suggestion of like how to get surgeons to operate. That's a different question. But if it's really how to help manage some of the behaviors, they typically are, so the Alzheimer's Association, regardless of whether a person has Alzheimer's or not, deal with the same sort of types of like memory loss and other cognitive issues that may come up. And I may not be hearing your question very well, but
No, and I don't know if other people out there are experiencing the same things, but I just find that he's had some really, really great improvements. I think that the diagnosis of normal pressure hydrocephalus was right on.
yeah,
But even professionals kept kind of walking backwards. So anytime he would have, reemergence of any symptoms, they would start saying, no, he has Alzheimer's. But no, he didn't have Alzheimer's. He just needed his adjusted.
yeah.
And so constantly coming up against that, no one really has the time or the interest, I'm not saying people aren't interested.
No, and I agree. I mean, and you are going to meet, unfortunately, the reality is that you're going to meet providers like that. And,
That's all I believe.
yeah, and it's hard. And to be fair, I mean, to those providers, some of them may not have experience with NPH, but other times it's, is the answer, if you readjust the shunt, do they get better? And if they don't get better, what's your answer then? And there's always risks to readjusting shunts, and I can see why somebody wouldn't want to do that necessarily in a 90-year-old. It just becomes a really, I'm not defending people. Obviously, I wasn't there and I don't make neurosurgical decisions, but it's a controversial diagnosis. And a lot of people are there's a degree of ageism as well that happens in the community, just the medical community in general. But the reality is that, yeah, if a patient is getting better from shunting and every time the shunt is adjusted, they get better. I mean, why not keep doing it? Why not try it again? And if it doesn't work the last time, if it doesn't work anymore, then maybe it's run its course, right? And then you can start thinking about other things. But yeah, I agree with you. It's a difficult
Well,
it's a
I think
difficult thing to manage.
the case here is that there is nowhere that specializes in normal pressure
Yeah.
hydrocephalus. So the neurosurgeons who do it, it's considered like, not exciting. It's not exciting surgery for them.
Yeah. Yeah.
Even though it makes huge differences in people's lives.
Yeah, it does. Yeah.
So I don't know if there are centers that specialize.
There are. Yeah. You can look on the Hydrocephalus Association. They have a network, collaborative network, and they have different things on there that look like that. Yeah. It's like a research network, but they're scattered kind of throughout the country, and there's not a lot of them.
Yeah, and Sarit, I will just for the sake of time, you can certainly email me and I can share some like programs throughout the country if you're willing to travel that focus on the condition. But you do need, as Dr. Schaffert said, you need experienced specialists that can kind of go through those motions with you. It's very difficult. But thank you, Dr. Schaffert, for answering.
Yeah, of course. Yeah.
So I will next is Sarah in line.
Oh.
Hi, my mother has NPH and has a shunt, and she did well with the gait and the urinary symptoms. But she has significant cognitive functions, and I'm trying to decide how important it is to distinguish between whether she has something like Lewy body or whether it's just, I mean, that's not just, but NPH. So is there a big difference in and it takes months and months to get a full evaluation like you're describing.
Yes.
Is there a big difference in the progression? I'm thinking like, planning for her future.
Yes, it's a good question. And it's variable a lot. So how old is your mother?
She's 82.
82. Okay. So at somebody who's in their 80s, the likelihood that they may have multiple things of NPH combined with something else is higher than it is at 72 or 62. Not saying that's diagnostic in any way. But as far as progression goes, it's not an easy answer. So some patients that have NPH can progress very rapidly into dementia. And some of that, we've seen actually that patients that have rapid progression typically respond better to a shunt, but there really aren't good long-term studies on progression of cognitive issues after a shunt. We really just don't know. Anecdotally, I think it varies from patient to patient, but as a whole, I wish we could give you a little bit more answers. Typically, if it's Alzheimer's disease, the time of progression from onset of symptoms to nursing home care is typically 8 years, but that can vary anywhere from 2 to 15 years. That's just average.
How about Lewy body?
Lewy body is typically a little bit faster, but the Lewy body disorders are really distinguished by having dream enactment behavior and visual hallucinations.
She has those, yeah.
Yeah, and so it might be that she has DLB. There are some more confirmatory diagnostic tests for that. So if you go to a good dementia, like Alzheimer's disease research center, or a good place that has dementia care with movement disorders neurologist, or behavioral memory disorders neurologists that specialize in that kind of thing, they can order a skin test to help really confirm the diagnosis of, and it's just a skin biopsy, and they look for the proteins that may be associated with DLB.
Maybe even though I have to wait months for the full neuropsych eval, maybe I could get them to do that.
You could, yeah, and it could be helpful. There's special imaging techniques, but I don't know, that look for dopamine issues. But I don't know if that actually would be interfered with the shunt or not. So I'm not sure
hard to
if that
get
would be a
those
good answer.
MRIs and stuff. Yeah.
But there is, it just came out the last couple years, and we're getting more data on it. It's a skin test for Lewy body pathology.
Excellent. Thank you.
And it can help because there are certain treatments that you would not want to have. So if you like neuroleptics or antipsychotic medications for patients that treat the visual hallucinations can be iatrogenic and actually make symptoms worse. So there's importance there, I think, for helping treating where the hallucinations are coming from. So I do think it's worth getting evaluated with it. But I think the progression I usually tell patients, and this goes for everybody, is that the progression that you've seen so far kind of establishes your trajectory, right? So if you're seeing a steep decline so far versus a more mild decline over time, you can kind of imagine that to be the typical trajectory that's going to happen, barring any other major medical events.
Oh, that's helpful. Thank you.
So I think that gives you a good idea of kind of where you are. But I would go ahead and, if it were my family member, I would want to know like what's causing this issue, because it could be a situation like maybe you need to get the shunt adjusted. It's hard to know, but if they have the hallucinations, I think, and the dream enactment, I think it's worth getting tested for it.
Okay. I will move forward on that. Thank you so much.
Thank you.
No problem.
Michael Todd, next in line. You have to unmute yourself, Michael.
Hi, thanks for giving me an opportunity to speak. Thank you, Jeff, for the program. And I want to thank Lakeisha too. She's been very helpful to me a couple of times, and I highly recommend you contact her if you have questions or need referrals to someone in your area or that sort of thing. So thank you both. I'm 73, in relatively good shape now, thanks to the surgery that I had in 2021. I'd gotten a pretty bad condition because I'd been misdiagnosed a few times for either bulging discs in my back, pressing on nerves that affected my legs and the way my walking. My father had Parkinson's disease, so there was concern that I was maybe pre-Parkinson's. Was this an early sign of onset of Alzheimer's? So it was pretty scary, but it took a long time for finally a neurologist here up in Brunswick, Maine, where I live, to say, let's look at your brain. And then I had the spinal tap and all that, and that set off the course of my surgery. And so I'm in much better shape. One of the concerns I have, though, is my need to, I at 3 o'clock or so every afternoon, it's like a switch is thrown and I just become very fatigued.
Mm.
and need a nap. And I think it affects my cognitive abilities and all of that. So I nap, and I put the question about this out to the Facebook group, the chat group, and I heard from a lot of other people who said, "Yeah, we do. Same thing happens here, but
Hmm.
it's probably just because you're getting older. Just enjoy your nap. Don't worry about it." So I'd like to know what you think about that. Is this something you hear about post-surgery from
I
people?
mean, that's a good question. I haven't heard that specifically. I could do a little bit of digging. This is why it's good to talk to people and so we can all learn from this. But no, I haven't heard of that. I think let me get off my stop sharing here so you all can see me a little bit better. So I haven't heard of that, but there are lots of things that cause fatigue, and patients that have neurologic disease or they have some issues. I wouldn't say it's directly related to the shunt, but in general, people that have things like MS, they have, any type of neurologic disease, they tend to have harder time managing their fatigue than patients that don't. So it could be just the factor of your NPH. The other things I would wonder about would be what's the quality of your sleep, and do you have any issues related to something like obstructive sleep apnea? Right? And so that can kind of be an issue. Like if you snore and you've been snoring for a long time, it may be worth getting tested to see, because that can be like daytime fatigue is a pretty prominent symptom, and afternoon fatigue and of obstructive sleep apnea. So,
I think
or
I'm sleeping very well. I don't think I have a problem with snoring, or my wife would have certainly let me know about that. Um,
well, that's good.
and again, I'm in
Yeah,
relatively good shape for my age and all
yeah,
that.
yeah.
Um, but
Well,
I wondered though, if because it took such a long time to be properly diagnosed and treated, could there have been damage to the brain from
hmm.
years of living with the excess of the
Yeah,
fluid?
well, it's possible. I wish I had a better answer for you. It's possible. I don't I don't know if it's going to be directly related to that. Uh, One thing you could try though is trying to see, if if you're doing like exercise in the morning or afternoon. Sometimes if people switch those a little bit, so they do a morning exercise versus they do an afternoon exercise, like maybe when you're starting to feel like tired or after lunch. There's also a really normal dip in our circadian rhythms at about 2 to 5 o'clock for most people. And so sometimes if you do a little bit of activity, you can kind of wake your brain up a little bit. If you do that, maybe you do go on a brisk walk at 1:30, like maybe an hour and a half before you typically crash, and just see if that helps improve some things. Um, I don't know what your heart conditions are, so I wouldn't recommend like just dousing yourself in coffee, but I know I take a
Yeah,
cup of coffee at about 2 o'clock in the afternoon every day too.
yeah, I'm
Uh,
good with coffee.
yeah, so it may be that you just have to try, some fatigue management strategies.
I mean, it may be my combination of medications I'm taking too. I
It's
should
really
talk to
non-specific. Yeah.
my primary care doc and see if he
Yeah, and
sees
it's
any
possible
issues
too. If
there.
you take anything sedating, you might want to move those to the evening and not take them in the morning.
Yeah.
So you could play around with that idea. I think maybe try a little bit of activity in the afternoon. Maybe it'll wake your brain up a little bit. It's hard
All
to
right.
know.
Thank you.
Yeah, no problem.
Thank you, Michael. Tim?
Yeah, I'm Tim Lockram. I'm 67 years old. I was diagnosed with NPH last year and I had a shunt put in September, and it has helped tremendously. I was basically having to use a wheelchair for a while last year, couldn't walk, and now I can walk easily with a cane, sometimes without a cane. So
Mm,
my cognitive abilities have improved dramatically too.
good.
Uh, my question is there any information on how long a shunt typically remains effective? And if it doesn't remain effective, can it be replaced? I'm just curious about that.
Well, certainly it can be adjusted if you have an adjustable shunt. It depends. If the shunt is operating correctly, they're likely not to replace it because it's just a lot of risk. There's actually more risk, I think, of replacing it just from an infection standpoint than there is from just going in the first time. The data suggest there are some studies that suggest that patients typically could have cognitive improvement for about a couple years after, and then some patients start to get worse again. What we don't know, though, is that if those patients are getting worse again because of the shunt malfunction, or just simply because they start having other disorders, Alzheimer's disease, other things that are going on, which is part of what Sarit's issue there with her father, and then the other case I can't remember. I'm sorry, I forgot your name, but with the DLB, it can become really tricky to know if those things are getting worse over time because of another disorder. There is some promising data of about a third to half of one study that showed that patients about 5 years showed good cognitive benefit, but that's one study. And the problem we have with any of these is that we don't have a good, when we don't have a good, solid clinical gold standard diagnosis for NPH, who we include in these studies varies widely. So it's hard to know, like, for example, in Parkinson's disease, we have criteria for you meet these features of Parkinsonism. We have to have 2 of these, 1 of these, 2 of these. They have to be going on for this long. They have to rule out other things, and then you have a gold standard of Parkinson's disease. In NPH, we have none of that. So it becomes a really tricky and problem for us from a research standpoint for us to say, the patients with NPH in general, because when you don't have we don't even know what that means from a clinical features or diagnostic standpoint. To get back to your question of like how long you would expect it to work, I would be optimistic and say I would hope that this is going to work for the rest of my life, because there are patients that do that, that have that. If you're noticing cognitive change, and you could go ahead and get a baseline, say, all right, I was here at age 67, age 68, and then 2 years from now, figure out where you are. Like that can help you figure out, is there cognitive change? Are we worried about something else coming on, or do we need to get the shunt adjusted? I hope that answers your question. I mean, it's kind of a long-winded response, but the answer is I don't know, to kind of shorten it down, but I would be optimistic, especially if you it's a good improvement.
And we have a question in the chat, and 2 people could not raise their hands, but someone asked about you reference ageism. What you explain that for?
Ageism. Yeah, what I mean is sometimes patients come into their doctor and they have memory problems or they have cognitive issues, and they don't get evaluated right away because it seems like it's at a normal part of the aging process. Or they feel like, what's the point? This person is going to pass away in a few years anyway. And that sounds really bad and morbid, right? But the reality of that is, yes, that happens.
Yeah.
I've seen patients, even in, with good doctors and good intent, that they don't get an MRI. They have cognitive problems, but they don't order an MRI, even though that's the gold standard. You need an MRI to help with the dementia diagnosis and what's causing a problem. So, even to the point where they're not getting good imaging results when they may have cognitive problems, right? So, or a good imaging referral. So that's what I mean when I talk about ageism. It's just the ability, like the lack of care, lack of resources, or lack of referrals because of a person's age.
Yeah, thank you. I hear that a lot when people call in, Dr. Schaffert. So I see Douglas could not raise his hand, and then Janine, I'll come to you. So Douglas first. Yes. You unmute yourself, Douglas. There you go.
I'm unmuted.
Unmuted.
So I'm 78. I'm had a shunt in let's see, 3 years ago, and it worked dramatically. It's an adjustable shunt, and I had it adjusted at the urging of my children about 4 months after it was installed because they noticed a decline
Mm.
or a change. I will say that I had immediate improvement after the surgery, like the next day. I should also say, just to throw this out there, my mother was diagnosed with NPH at 84, and she lived until she was 94, and with the shunt, the same shunt, that it was checked, but never adjusted. So, and she got 10 years, of which the last couple may have been dementia related, but she was amazing. She had the surgery. She was incontinent, confused as can be. She had the surgery, and within 3 days, she's back doing a New York Times crossword puzzle in ink. It's like we just floored us all.
Mm-hmm.
So then she was 84. She came down, and I think that I had symptoms about 6 years ago, that it was tangled up with a bad back,
Mm-hmm.
which confused the gait issue.
Mm-hmm.
I opted for 2 lumbar punctures just to make sure it was the right thing to do. And it was the right thing to do. And those are, for me, were very effective.
Mm-hmm.
My question that is, can NPH affect the vestibular system? And I have, really lucky. I'm very active and stuff, but my balance is a little off.
Mm-hmm.
And I do PT for it.
Mm-hmm. Well, I don't know the answer to that. The question, I guess, is that if you have dizziness and other things, it could be a vestibular or inner ear issue. The balance issues could be residual problems with NPH. It can affect your balance, but balance is affected by a number of things. Balance is affected by any sensation you may have in your legs and your feet. People with loss of sensation in their feet may have problems with their balance because they can't feel as much. They may have vision problems that affects the ability for the brain to kind of see where they are in space, right? And kind of orient themselves and have a balance issue there. I would say I would keep working with your physical therapist and trying different things and seeing what works. I don't have a good answer for you as far as is it due to the NPH or not. It certainly could be. Or it could just be something that is just not completely recovered, and it may not recover. But I would say let's try to improve it as much as you can with the physical therapy and see what works best for you. But yeah, it's a hard question to answer. I wish, again, all of this highlights the problems we have with NPH and all the symptoms because it can be so many different things.
I will add one thing, is that immediately I have what's it called, treatment-resistant depression. And the day after the surgery, it was gone, absolutely gone, and it stayed gone for about 6 months. It was an amazing thing.
Wow.
I throw that out there is because there isn't enough information floating around.
No, and I've seen that too. I've seen patients that have a lot of apathy, lack of motivation, problems initiating. You can see those behavioral changes with NPH, and they can turn into depression, or they can be confused with depression, and they can get better. Yeah, thank you for sharing that.
Thank you, Douglas. We're close. I mean, we're over a little bit of time, so Janine and then Gary will take it away.
I've had some very complicated issues. I had a Medtronic shunt put in 1 year ago today. 4 months later, I had a second one put in, and my neurosurgeon sent the first one back to Medtronic, and Medtronic said, no, it's working fine. So when the second one was going bad after like a week, Medtronic gave my son one of the measurement kits, and you can change it and all that. My son's a doctor, so they felt confident he could do that. Because my settings change every other day. We set it, 2 days later, it's off. Set it again, 2 days off, it's off. Saw Dr. White, yay, about a week ago, and he's never heard of that. His thought is it possibly was not installed correctly. I don't know how it gets installed incorrectly from a neurosurgeon, but maybe. And so I see him again in 2 weeks. He did a spinal tap on me recently, and I have no markers for Alzheimer's. So that's good. So, and, I start having all my problems again, like 3 days after the shunt's put in. My walking, my gait, urinary is the only thing I haven't had. Have you ever heard of anything like this happening?
Well, if Dr. White's never heard of it before, I sure as hell haven't heard of it before.
Yeah,
He's been doing this a lot longer than I have.
Yeah.
I haven't, unfortunately. I'm so sorry, Janine, that's happening to you.
Yeah, I just, I feel good for 2 days, and then it goes off. It'll go from, well, right now my shunt is supposed to be at 0.5.
Yeah.
And it can't go. And it started off at 1.5.
Wow.
Now, and we set it back to 0.5. And then 2 days later, it will be up to 0.5 or 2.
Wow.
And this keeps going on. I'm just glad my son has the kit that he can keep measuring it. I go in every other day for my measurement, going in right after this meeting.
Yeah. Well, it makes you wonder a little bit about
anything magnetic in your house?
Oh, no, we've gone over this like 4 times now.
Yeah, that's so strange.
I'm not near anything that's magnet.
Yeah.
I'm just a little old lady who plays in her backyard with her flower beds.
Yeah. Well, I'm sorry. I wish I don't have an answer for you on that one. It's beyond my pay grade. Yeah, somebody said in the chat, just 2 more things real quick. Father, exercise regularly helps with cognition dramatically. Yes, exercise, 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 exercise. I tell all my patients to do that. It helps with all sorts of things, not just your cognition. And the other question is brain biopsies. Well, Angela, I hope maybe you can contact the NIH or the Abdominal Brain Institute and fund my research to look at brain biopsies when they're doing shunts. If they're open and you're in there, I feel like a lot of you would have agreed to do a brain biopsy because it's minimal risk and it tells you kind of what the prognosis is over time because it looks for the proteins that may be associated with other disorders. And the same thing for people that get their spinal tap. You're already doing an invasive procedure. Look for other disorders because it's a tricky diagnosis to make. So a good question. Brain biopsies are something that does happen in some centers. We are not routinely doing them, but hopefully we will get some funding someday so we can do that. But it's a good question. So just a little plug for us to try to do that.
Spinal tap a week ago.
Yeah.
So
yeah,
we don't know what's going on, and I'm take it not seriously. I'm ready to blow my brains out because we can't get it to work.
I imagine it's very frustrating.
And I used to be a long distance biker, 50 to 75 miles. I look at my bike and I just cry because I can't even get close to my bike and think about ever riding again. I just hope Dr. White has another idea when I see him next week. But I think what he's going to do is go in and do a different shunt because then Medtronics will be out of the picture. So we know it won't be that. And then if these other ones, he then might know it was installed improperly. I don't know.
Yeah.
And he doesn't know right now. So he might see it then. So he is going to put in a 3rd shunt. And this is all within a year.
Wow.
Wow. And Janine, thank you for sharing. For the sake, just to spare time. We're taking a lot of Dr. Schaffert's
That's
time.
fine. Not a problem.
And I'll just let Gary take it over.
Okay. Thank you all. I'm gonna step off now, but thank you all very much.
Actually, I do have one
Oh, go
comment
ahead.
I could have heard. I'm very, very thankful, even more thankful after this conversation, that I have been a patient at UT Southwest for all these years, because I'm very fortunate in that some of these issues have been taken care of along the way. And one thing that came up that just a few questions back was about the effectiveness of the shunt over time. The one thing I would like to just clarify for people is that, like for me, I've had multiple shunts put in because I have an issue with my shunts clogging. So if you're going to your neurosurgeon and you do see that things are not working the way they were a year ago, possibly just an adjustment is going to be needed. I'm here to tell you, just don't give up with the first thing that they tell you that is probably not going to work. Go that next step, because really what they need to be doing is that if adjustments don't work, but symptoms do increase, that's a time when they can do a study like a shunt tap or something like that to just verify that the shunt is physically working. In my case, I'm fortunate in that every time I've had my shunt replaced, I come way back. I mean, I tell people I don't bounce quite as quick or quite as high as I used to, but I still have this dramatic impact that allows me to know that working a shunt is a good thing to happen. So if your neurosurgeon doesn't offer that test, put a little resistance out there that you want to make sure the shunt is working before you, or not working before you just simply give up. Don't give up. So I was thinking that I'm on shunt number 8, and I just found out from our social media the other day there was a guy on there with NPH who was on shunt number 12. So I've lost my record. So so those are the things I wanted to be very thankful of where I'm getting my treatment. Push your neurosurgeons and your medical team in that direction, because it can make a big difference. And Dr. Schaffert, I really appreciate the fact that you spent your time with us, and that we kept you overtime and you answered all these questions. And you can just see from the number of people that were here and that they signed up or got online so early that there's a lot of interest in there. And with that, you have a good evening.
Thank you. I appreciate
Thank you, Dr. Schaffert.
everyone's attentiveness, and I hope I can do this again someday. I hope all of you the best.
Great.
Have a
And
good
Gary, I'm going to try to call
Bye,
you. I
Dr.
think I've
Schaffert.
got your phone number someplace.
Okay, sounds good. All right,
Okay.
bye-bye.
Thank you.
All right, Gary, have your way.
All right. Well, that was a